And it's my pleasure to start the session by introducing Dr. Iftikhar Kulo, professor at the Mayo Clinic in Rochester and the director of the Familial Hypercholesterolemia and the Early Atherosclerosis Clinic. Please.
Good morning, everybody, and I would like to thank the organizers for the invitation to this beautiful city and the venue. And over the next 20 minutes, I'll try to give you an update on familial hypercholesterolemia. And this is the outline of my talk, a brief historical perspective, and also explain the genetic basis of this condition, how it presents in the clinic, how often it's prevalent in the community, and how can we reduce the burden of this condition using cascade screening, and then finally some comments on how we might treat this condition. So this is a relatively common condition, and unfortunately it may often presents as sudden death or heart attack. So here's a case, a 35-year-old woman with ST elevation anterior MI. She has these stigmata on examination. She has xanthomas and an arcus senilis, which is very characteristic of FH. Her total cholesterol is 338. Her LDL is quite high at 285, and her lipoprotein A is also elevated. And when you take a family history, her father had an MI, mother had an MI at age 50, and she had the MI at age 30. And then it turns out that her son, who's 7, also has the disease with an LDL of 271. So this disease was first recognized, interestingly, by dermatologists way back because it usually presented with xanthomata. And the connection wasn't made until 1938 by a Norwegian physician, Müller, who noted that these individuals had high cholesterol and presented with myocardial infarction at an early age. And in 1964, Kashdurian found that the segregation, the way it was presenting in families, suggested an autosomal dominant disorder with a single gene defect. And then in 1967, Fredrickson further outlined the role of lipoproteins in this condition. And then 1974, Brown and Goldstein, in their very famous work, pointed out that this disorder was actually from a defect in the LDL receptor, and this work led to the Nobel Prize for them. So it is an autosomal dominant genetic disorder, and this is a pretty characteristic pedigree for this condition. 50% of the first degree relatives have a chance of having it. And it's caused by more than one gene, so that means it's heterogeneous in terms of the locus. And within a gene, there are many variants that can cause this condition. The penetrance can be variable. Some of the mutations are less likely to cause very high levels, whereas others are associated with high levels and premature coronary artery disease. So this is just a movie to show how LDL is metabolized. It's usually processed by the liver. The LDL particle attaches to the LDL receptor shown here on the liver surface. It is internalized and packaged in this vesicle, the clathrin-coated vesicle, which merges with the lysosome where the cholesterol is degraded. And the receptor is set free so that it can recycle back to the surface of the liver, where it can continue absorbing more LDL from the circulation. So when the receptor level goes down, as you see here, the cholesterol levels are very high. And this is the condition where we see in FH, where the receptor is defective or very high. So this is caused by 3 genes. LDL is the most common, ApoB the next, and PCSK9 is about 2%. And you can see that this condition, the LDL receptor being defective, means that the LDL levels go very high in the circulation, and they accumulate in the arteries and often in the cornea or in the tendons. PCSK9 is a mediator of degradation of the receptor. So if it's in the endosome that I just showed you, PCSK9, rather than allowing the receptor to go back to the liver, targets it for its degradation, and therefore the number of receptors on the surface of the liver are lessened and the levels go up. So if we inhibit PCSK9, as we do with PCSK9 inhibitors, then we see that the levels of LDL also go down. So there are individuals that can have the genetic diagnosis of or the clinical diagnosis of FH, but they do not have the mutation, and we don't know what the cause of high levels. It may be that there are other mutations we don't know about, and then there are patients who have the mutation, but their LDL levels are rather modest, and that's varying penetrance of this condition. So if we look at these individuals that have high cholesterol, they have a mutation in LDLR, ApoB, or PCSK9. Some of them are polygenic or non-polygenic, and some are, a large majority of them are polygenic. In other words, they have small effects of many genes that leads to high cholesterol. And some of these non-polygenic may be due to new mutations that we don't know about yet, or we haven't discovered them yet. So how does a patient with FH present? Well, typically they have family history of early disease. They have a personal history of early disease, MI usually. They may have xanthomata, they may have an arcus senolis in the cornea, and they may have aortic stenosis, particularly if they have concomitant elevations in lipoprotein A. Typically, we will order additional testing, such as measuring lipoprotein A level, assessing subclinical disease burden through coronary calcification, and echocardiography if the patient has aortic stenosis, murmur, and then stress testing if they have any suggestion of angina. So the expression of this disorder doesn't just depend on the mutation, but also whether there are other metabolic conditions present, for example, diabetes, but what's the environment, the diet and lifestyle, whether that person has been treated with medications early on, whether they have concomitant elevations in lipoprotein A, and potentially other genetic factors also modify the expression of this condition. How do we diagnose FH? Well, there are established criteria. The two most common ones are the Dutch Lipid Clinic Network criteria, which are basically dependent on the degree of elevation of the LDL cholesterol, the presence of xanthomata or arcus, personal history of ASCVD, family history, or either high cholesterol or ASCVD, and then a positive genetic test. The other criteria that are used are the Simon-Broom criteria, where you need a cholesterol of greater than 290 or an LDL of greater than 190, and then if the patient has tendon xanthoma or a positive genetic test, that's definite FH. If they just have a family history of early onset myocardial infarction or high cholesterol, that's probable FH. Now, it's a relatively prevalent condition, and in this study we did at Mayo, we looked at 130,000 individuals in our practice and looked at their cholesterol levels and the presence of criteria for FH, and we found a prevalence of about 1 in 310, but only half of them had an ICD code of hypercholesterolemia, and an ideal LDL of less than 100 was achieved only in 50%. So this underscores that we have to do better in terms of awareness and detection and treatment of this condition. And if you look at, so this is prevalence based on clinical criteria, but if you look at genotypic prevalence, it seems to be higher. So this is, to my knowledge, the largest study in the US, where they had 50,000 individuals that underwent genetic testing, and they found a prevalence of 1 in 222, which is really high for an autosomal dominant condition. This might be just about the most common autosomal dominant condition in cardiovascular diseases. And when they separated out patients who had been recruited from the cardiac cath lab, which I guess would be biased, more likely to have this mutation, even then the prevalence was 1 in 250. So relatively high prevalence, and that's why we need to be really aware of this condition to detect it and treat it. Now, interestingly, the degree of the kind of mutation you have will influence how high the LDL levels are. So in this slide, we see that compared to those that don't have a mutation, people obviously that have a mutation in one of these genes will have higher LDL levels. That's a given. But then if you separate that group out, you see that the highest LDL levels are in those that have an LDLR mutation. And then ApoB mutations are generally associated with a milder phenotype and lower LDL levels than LDLR mutations. And then PCSK9 seems to be next in terms of the degree of elevation. And this transmits to clinical presentation. So if you now compare the risk of CHD in these various categories, Obviously, it's elevated whenever you have a mutation in any of these genes, but the risk is highest if you have a mutation in LDLR. And within that gene, if you have a loss of function mutation, that has the very highest risk. And then ApoB and PCSK9 mutations are also associated with higher risk, but it's not as high as with an LDL mutation, or an LDLR mutation, I should say. So to really make an impact on early detection and prevalence, we need to be aware of cascade screening. And cascade screening is simply screening when you have a proband who's had the disease. So in this family, you see that the dad had passed away of early onset MI, and then the siblings, the children got screened, and of the three children, one or two have the mutation shown here, and then if they screen their children, they have a 50% chance of, the children have a 50% chance of having the mutation. So if we continue to carry on like this, we do a cascade, we are more likely to find new patients, and we can then treat them before they develop cardiovascular complications. This is why we should cascade screen using genetic testing, not LDL levels. And this is why we should do it. If you take relatives or patients who have FH and measure their cholesterol, then those that have the mutation are shown at the bottom, and they obviously will have higher levels as shown in this graph. And those that don't have the mutation, this is the distribution of LDL. Now you can see that's a considerable overlap. So LDL levels by themselves may not be reliable, but the genotype is absolutely reliable, and that's why cascade screening is best done by genotyping. And this allows for unambiguous diagnosis in relatives. It's cost effective. This has been spectacularly effective in Netherlands, and they found that the cost per life year gain was only $8,700. And they really led the way in cascade screening, where over a period of 10 years, they've detected more than 20,000 cases and have been able to prevent many, many early premature events in these patients. Now in the US, we don't have a cascade screening program. It's usually present in those countries that have a national health system. And what we're trying to do in the FH clinic is that when we see the patient and we draw the pedigree, the genetic counselor does this, then the relatives are contacted through the patient. Now, because of privacy laws in the US, we are not able to contact the family directly. So we have to request the patient with the proband to then contact the relatives, who are then offered a DNA test and as well as a lipid profile. And if FH is confirmed, then we see these patients in the clinic. So we recently made a case for a national cascade screening program. There are various proponents of a universal lipid screening, but clearly I think the cascade screening has been well demonstrated to be cost effective and efficient. And what we need to do is use health information technology, websites, patient portals, decision support, and also public outreach and education so that we can make people aware of this possibility to detect relatives early on and treat them before they develop early onset MI. So this is one of the tools that we are using, a website. So instead of having us tell the patient to contact their relatives, they can actually contact them through the website, and those individuals can then contact us through this website to set up appointments for genetic testing or lipid screening. Just a broad outline of treatment. So any patient that you have, that you suspect FH, the first thing is to rule out secondary causes. Is there hypothyroidism? Is there kidney disease? Is there liver disease? Is there diabetes? Once you rule that out, you can then try to establish a diagnosis based on the criteria that I described, the DLCN or the Simon-Broom. That's based on these particular features. And then additional testing could include lipoprotein A levels, coronary calcification, echo or stress testing. And then we generally counsel patients on cascade screening, on diet, physical activity. And then, of course, statins are the mainstay of treatment, plus ezetimibe. And once you are maxed out on those and you're still not at goal, then PCSK9 inhibitors. And I think Dr. Nichols is going to talk about that in his talk. And when you're still not at goal with all of these medications, then lipoprotein apheresis remains an option. Typically, the FDA-approved criteria are an LDL greater than 500 in homozygous FH, LDL greater than 300 in heterozygous FH, or an LDL greater than 200 in a FH patient who already has coronary artery disease. And then generally the average LDL cholesterol lowering is about 60% from baseline with lipoprotein apheresis. What about children? Well, there's data that statins do not affect growth, maturation, or education levels, and one can start these medications as early as 8 years with pravastatin or 10 years with simvastatin and other statins. Pitavastatin has had good data for children of Asian descent, and then the treatment goal is generally lowering the LDL to the less than the 95th percentile for that age, or 50% from baseline. We can also use ezetimibe and a resin starting from age 10. There's data that those are safe starting at that age. And lipoprotein apheresis is often needed when the patient has homozygous FH and the levels are very high. So to summarize, the recent advances in FH in the US, we now had an ICD-10 code for FH that hopefully will translate into greater awareness and detection of this condition. There's increasing recognition that cascade screening by genetic testing, and now even by direct-to-consumer, there are actually companies in the US that will do a direct-to-consumer test of these 3 genes, and then also the relatives if the test is positive. There's data showing that intensive LDL reduction as early as possible is beneficial, and then recently with PCSK9 inhibitors and even other new drugs have emerged that have promise for the high-risk severe FH patient. The FH clinic, I just want to briefly describe that for you. So here we have a cardiologist who is an expert in genomics, seeing the patient together with a genetic counselor, and we draw the pedigree, we counsel the patient on cascade screening, and then we obtain pre-authorization for genetic testing, which is needed in the US. Lab tests are reviewed, and often we face a variant of uncertain significance, and this remains a problem. We are setting up functional assays for LDL receptor, for example, to better understand what those variants mean. But otherwise, if there's a pathogenic variant, then of course we initiate cascade screening. And if there's no pathogenic variant, but the person program looks like he has FH, then we are considering whole exome sequencing in families of these individuals to identify new genes eventually. So I'd like to end here and would be happy to take questions either now or at the end of the program and acknowledge the funding sources. Thank you very much.
So if we can maybe take a few questions before moving to the next speaker. So maybe till the audience will have some question. Can I ask you, those patients who find a positive mutation, but their LDL cholesterol, let's say it's in the controlled, somewhere between 100 to 130. So what do you do with these patients?
That's an excellent question. So there's some data that if you have a mutation, even if your LDL levels are not very high, you might be at a higher risk. There's some data to suggest that. So I think that my threshold for treatment or LDL lowering would be low in those individuals. I might resort to subclinical disease assessment to see if they, for example, have coronary calcification or plaque on the carotid, and then I would definitely treat them even if their LDL levels were not very high. But because of the mutation, the person is exposed to high levels in utero. So that's why even if the LDL is just modestly elevated, the risk may be out of proportion to just the level of LDL, just because of the amount of time that the exposure has occurred is quite long. So the threshold for treatment would be low, and I would still potentially look for subclinical disease in those individuals, and that would be won't have any hesitation treating them if they have any evidence of calcification, for example.
Yes.
Dr. Bruno, thanks for the great talk. So I have a question about, there was a recent Spanish study in September, so in JAG, which looked at ACS patients less than 65 years of age, and they found that 10% of them had FH. So how are you applying that in clinical practice, and now raising the age bar to having cascade screening and so on?
Sure, I think that's a great area where one can detect more patients, because many of the patients that we see that have an early onset, the prevalence of FH is pretty high, and it has been noted to be as high as 14%, 7 to 14%. So I would say that any patient that has a premature event, one should be very suspicious of an underlying FH. I think for two reasons. First of all, it informs the management of that patient, but more importantly, I would say it can help detect the relatives of that patient by cascade screening. So in our practice, we generally will see those in the early atherosclerosis clinic, and we would be very suspicious of an underlying FH in that situation.
Yeah, so the age now, so usually we used to look at younger people, and now we're starting to look at even people within the 60s, early 60s.
Yeah, I think that we now realize that it may not always be the classical early onset, and people, particularly women, can present later with an event, even if they have FH. They may present quite late in age. So there's a good rationale for potentially screening, particularly if the person does have history of high cholesterol in the past, to screen for FH.
Thank you.
Okay, so if there's no any more questions, thank you very much, Dr. Iftikhar. So we'll move to the next speaker, Professor Stephen Nicholas. I think he was introduced in the first session. So he is going to talk about influencing atherosclerotic plaque results of recent trials.
Yeah, in fact, I think I'm talking about PCSK9 inhibitors with the change to the program, Mr. Chair. Good morning again. And to follow on from the last presentation, what we've seen since the early 2000s has been a rapid transition of the PCSK9 story. You saw the video of LDL particle uptake by the liver in the last presentation, and what we've learned since 2003 is that PCSK9 is an important factor in regulating LDL receptor expression on the hepatocyte surface. As you saw earlier, we know that the normal function and interaction of the LDL particle and the LDL receptor is for that complex to be internalized into the liver. What ideally should happen, as was demonstrated, is dissociation of the LDL particle from the receptor. LDL particle and its cholesterol can then be dealt with within the lysosome. And that should permit the LDL receptor to shuttle back to the hepatocyte surface so it can continue to remove excess LDL particles from the circulation. We know that PCSK9 in the systemic circulation will bind to that receptor LDL particle complex and then prevent that dissociation within the liver, and therefore prevent ongoing reshuttling of the LDL receptor to hepatocyte surface, and so will limit the ability to remove excess cholesterol from the circulation and result in higher LDL cholesterol levels. What we've seen, in addition to understanding the genetics and the biochemistry of PCSK9, is we've really seen the rapid translation of a range of therapeutics in this space, with the hope that the ability to inhibit PCSK9 might, one, lower LDL cholesterol, and then that might translate to improved cardiovascular outcomes to patients. And what we've seen is that the majority of the work in that space has really been with the development of monoclonal antibodies. Firstly, humanized, and then finally fully human monoclonal antibodies, which have been targeted against PCSK9, administered by subcutaneous injection, either 2 weekly or once a month. And here you see fairly typical data that we've seen from a large number of lipid-lowering trials of these agents over the course of the last 5 or 6 years. Whether administered either as monotherapy or in combination with a statin, we see dose-dependent reduction in LDL cholesterol levels in the up to 60%. And that really provides considerable therapeutic opportunity, not only for the patient with very high LDL cholesterol levels, as we've just heard, patient with familial hypercholesterolemia, also patients who can't achieve effective lipid lowering with maximally tolerated statin therapy, but at the other end gives the opportunity on top of a statin to lower LDL cholesterol levels to very low levels, down to the point that we see when people are typically born, well down below 40 milligrams per deciliter, and it really enables for us to ask the question, will we see even greater clinical benefit by adding these agents on top of a statin for patients at high risk for a cardiovascular event? And what we've seen over the course of the last year and a half have been a number of reports of trials that have really tried to extend our understanding of PCSK9 inhibitors. The first was a study that we conducted called GLAGOV. This was a serial coronary imaging study using intravascular ultrasound. We had previously used that technique that demonstrated the benefits of increasing intensity statin therapy, and we've been able to demonstrate down to a level of 60 milligrams per deciliter that there was a direct relationship between the degree of lipid lowering of a statin and the ability in the first instance to slow disease progression, but ultimately at lower levels, below 70 milligrams per deciliter, to be able to promote disease regression. And so what we wanted to do in GLAGOV was to take nearly 1,000 patients with angiographic coronary disease who had been treated with a stable dose of statin therapy for at least 4 weeks, 2/3 of which were on intensive statin therapy. So these were very well-treated patients. They needed to have an LDL cholesterol that was greater than or equal to 80 milligrams per deciliter despite that therapy, or between 60 and 80 milligrams per deciliter, provided that they had additional risk factors for ongoing disease progression. We performed an intravascular ultrasound examination in a coronary artery at baseline, and following 18 months of treatment with either placebo or the PCSK9 inhibitor evolocumab, administered once a month in addition to their intensive statin therapy. What we observed in that study was that there was a profound difference in lipid levels between the two groups. In the statin alone group, patients had an LDL cholesterol on treatment of 93 milligrams per deciliter. When evolocumab was added to their statin therapy, in the other group, the LDL cholesterol on treatment was just below 37 milligrams per deciliter. So we saw a difference in lipid levels that was predicted and very consistent with prior lipid studies of these agents. And when we looked at coronary atheroma burden, it translated to a profound benefit. We saw no change in plaque burden in the patients who continued to be treated with their statin over time, but in the patients in whom we added evolocumab to their statin achieve a much lower LDL cholesterol below 40 milligrams per deciliter, we see regression of coronary atherosclerosis. Not only do we see regression of disease overall, but we see a greater percentage of patients who are treated with evolocumab in addition to statin therapy achieve any degree of disease regression. In orange, in blue, on the left, the patients who was treated with statin monotherapy alone, 47.3% of those patients demonstrate some degree of regression of disease over the course of the study. On the right, you'll notice that when evolocumab is added to the statin, it's now 64.3% of patients demonstrate some regression. So not only do we see more regression, but we see it in a greater proportion of individuals. The somewhat sobering observation in orange on the right is that nearly 36% of patients who had a PCSK9 inhibitor added to their statin therapy continue to demonstrate some degree of ongoing disease progression. That study suggesting that there are other factors that are continuing to drive ongoing disease progression in those individuals. When we looked at the relationship between the achieved level of LDL cholesterol on the horizontal axis and the rate of disease progression on the vertical axis, we see that this is a linear relationship all the way down to 20 milligrams per deciliter. And that's an important observation because in addition to asking the question, would evolocumab produce an incremental benefit for patients, another major objective of this study was to ask the question, would we get down to a low level of LDL cholesterol below which you would no longer continue to see a greater benefit? And down to 20 milligrams per deciliter, the answer to that question is no. The lower you go, the better you do. And we've seen very similar data now reported in the cardiovascular outcome trial data that I will summarise in a few minutes. At the European Society of Cardiology meeting last year, we reported the composition changes that we observed in the patients treated with evolocumab and statins. And what we observed was very similar findings to what we had previously seen with our experience of high-intensity statin therapy, that regression of disease that you see is associated with small reductions in fibrous and fibrofatty material. What's particularly striking is that the major compositional change that occurs with intensive lipid-lowering therapy, whether it's with high-intensity statin therapy or whether it's with a PCSK9 inhibitor added to statin therapy, is actually an increase in plaque calcification. So we think that intensive lipid lowering with these agents reduces the size of coronary atheroma burden, and that the plaque that remains is likely to be more calcified and therefore more stable and less likely to translate to a cardiovascular event. At the ACC meeting last year, we saw the first of the large cardiovascular outcome trials of the PCSK9 inhibitors reported. The Fourier study enrolled over 27,000 high-risk patients who had a prior myocardial infarction, prior stroke or symptomatic peripheral arterial disease. They had to have an LDL cholesterol on intensive statin therapy greater than or equal to 70 milligrams per deciliter, or a non-HDL cholesterol greater than or equal to 100 milligrams per deciliter. And then patients were randomised to receive treatment with evolocumab or placebo, on this occasion every 2 weeks or once a month, and that was entirely left up to patient preference. The majority, interestingly, chose the 2 weekly administration in this study. Here you see the lipid levels during the course of the trial, very similar to what I've already shown you in GLAGOV, a 59% reduction in LDL cholesterol with mean LDL cholesterol in the evolocumab statin group of 30 milligrams per deciliter. When we looked at the primary endpoint, which is a combination of cardiovascular death, MI, stroke, hospitalisation for unstable angina or coronary vascularization, we saw a highly statistically significant 15% reduction in that composite primary endpoint. Importantly, the curves take at least 6 months before they start to separate. So just like I'd made the comment in my prior talk on diabetes drugs and had referred to the early experience with the statin trials in the 1990s, lipid lowering often takes some time before you start to see a benefit. And so it may have potentially been that if the patients overall had been followed for longer, we may have seen a greater benefit. When we look at the key secondary endpoint of cardiovascular death, myocardial infarction and stroke, here you see when you look at the harder triple endpoint, you see a 20% reduction in that parameter in favour of evolocumab compared to placebo on top of statin therapy. And so when we look at the achieved levels of LDL cholesterol versus the rate of cardiovascular death, MI and stroke, again you see this direct relationship, the lower the better. And as I said, now both from the imaging trial and the cardiovascular outcome trial perspective, we're able to draw that line down to a much lower level of LDL cholesterol, demonstrating increasing benefit for high-risk patients. As I said, the Fourier study, while a big study, had a relatively modest treatment duration. The median treatment duration in the study was 26 months. Many patients, in fact, have been treated for the better part of only a year. And when they increased the sample size of the study, the steering committee had anticipated that they may in fact end up with many patients with a relatively short treatment duration, and had pre-specified a landmark analysis where they would look at both the primary and secondary endpoints, both during the first year on the left and after the first year on the right. Here you see the results for that key secondary endpoint. During the first year, a 16% relative risk reduction in favour of evolocumab from 12 months and beyond. In fact, a much greater relative risk reduction, again suggesting not only the lower the better for longer was likely to achieve the greatest benefit for patients in this trial. In terms of safety, it was very reassuring. We saw no increase in either adverse events or serious adverse events, no concern in terms of excess injection site reactions, no excess in terms of the types of adverse events that have certainly occupied a lot of interest in the popular media in terms of statins, whether that's myalgia, cataracts, reports of new onset diabetes, or neurocognitive adverse events. Importantly, we saw no appearance whatsoever of neutralising antibodies with evolocumab, which has important implications in terms of other programs that have been reported out. Within that study, the investigators planned a large sub-study to evaluate neurocognitive function. In fact, nearly 2,000 patients underwent serial assessment of neurocognitive function using a well-validated assessment of executive function. Nearly 1,200 of those patients actually had their baseline assessment prior to receiving the first dose of study drug. And very reassuringly, doesn't matter which of the endpoints that you look at, we saw no difference between the two treatment groups, either at baseline, on treatment, or the change in those scores, suggesting that there was no early signal of neurocognitive abnormality that appeared using a well-validated assay in that space. Similarly, we see no difference in the changes in those parameters in patients stratified according to the achieved level of LDL cholesterol. So not only were there potentially theoretical concerns about the administration of monoclonal antibodies and their effects on PCSK9 inhibitors, but other people may have potentially been concerned about the effects of achieving very low LDL cholesterol levels on neurocognitive function. Again, very reassuringly, the results of this large sub-study of the Fourier trial suggest that we see no signal whatsoever at very low LDL cholesterol levels, again reinforcing the safety evaluation in that trial. Now, at the same time at the ACC, we saw the report of a second outcome trial program, the SPIRE cardiovascular outcomes program, which involved administration of brocakizumab. This is a humanized, not fully human, monoclonal antibody against PCSK9, and two large cardiovascular outcome trials were in progress when the program was aborted, and it was aborted due to the discovery that over time a considerable proportion of patients treated with this agent developed neutralising antibodies and accordingly had a loss of lipid-lowering efficacy over time. Here you see the results looking at cardiovascular events of the SPIRE-2 study, and I put that up there because to get into SPIRE-2 you needed to have an LDL cholesterol greater than 100 milligrams per deciliter or a non-HDL greater than 130 milligrams per deciliter to get in. And even with a study that was stopped early, with only about 400 cardiovascular events accrued, there started to emerge a statistically significant difference between the two groups in terms of cardiovascular events, and it very much reinforced the potential benefits not only of treating patients with a PCSK9 inhibitor, but specifically targeting patients with very high LDL cholesterol levels coming in. And then the third study, which we hope to see the results of this year, are the Odyssey Outcome Study. This is a post-ACS study of alirocumab, 18,000 patients greater than 40 years of age who are between, in fact, 4 and 52 weeks following an acute coronary syndrome. Patients randomised to alirocumab or placebo on top of, again, intensive statin therapy. We should see the results of that trial, hopefully, in the next few months as the next instalment in understanding effects of PCSK9 inhibition on cardiovascular risk. So the benefits are great. We can now translate the benefits of PCSK9 inhibitors from the blood to the artery wall and ultimately to cardiovascular outcomes. The data to date at least looks reassuring from a safety perspective, and now we are really faced with the challenge in terms of clinical implementation, and the 800-pound gorilla in the room in terms of how to effectively use these agents is the cost. These are not cheap therapies, and we are all struggling worldwide in terms of how we cost effectively use these agents. And to date, it's been relatively limited in most countries, largely to the FH arena, or potentially at least to an argument where patients are at particularly high risk, even despite use of maximally tolerated doses of statin therapy. There are alternative approaches to targeting PCSK9. The monoclonal antibodies target PCSK9 in the systemic circulation. There are approaches that have been developed that will actually reduce RNA synthesis directly in the liver, and certainly early experience with those agents shows very robust lowering of PCSK9, a very comparable degree of lipid lowering as we've seen with the monoclonal approach, but potentially quite reassuring, a much more durable effect because this is now reducing the synthesis of PCSK9, stopping it from getting into the blood in the first place. And so has the potential to be a therapeutic which one might be cheaper, but importantly might be a therapeutic that may only need to be administered 2, 3 or 4 times a year. And that may change the clinical setting of administration from a patient at home every 2 weeks to a nurse in a clinic every 3 or 4 months. Again, safety is going to be an absolutely critical evaluation in the clinical development program here as we're directly targeting RNA synthesis in the liver. And so this program, while very exciting, has a long way to go and will need large studies, not only to look at cardiovascular benefits, but importantly to provide the kind of safety reassurance that we would need for that to be an effective therapeutic moving forward. So that gives you a Cook's tour of where I think the last 2 years in particular have been in this field. There is ongoing work, and 2018 has a great opportunity to provide many more answers. Will longer follow-up that is being seen in the Odyssey Outcomes trial translate to greater clinical benefit? Hopefully we'll get the answers to that soon. What will the true cost effectiveness look like? And that's likely to be a different answer in different countries. What are the groups that stand to benefit the most from administration of these agents? I think patients with FH are the first important group of patients who are likely to benefit the most. Secondly, those patients at high CV risk who have persistently elevated LDL cholesterol levels in the presence or absence of statin intolerance, and I think SPIRE-2 provides very important data to support that. And then finally, I think the subgroup data that we're starting to see emerge from Fourier and ultimately from Odyssey Outcomes, if it is positive, will tell us which other groups may have a high degree of modifiable risk. And we've seen some really important observations both at ESC and AHA suggesting, for example, patients with peripheral arterial disease really appear to derive quite a significant benefit and may be, again, a potentially cost-effective group for use of these agents. And then finally, how will RNA inhibition of PCSK9 influence clinical practice? The clinical trials will answer that question. And I thank you for your attention.
Thank you, Dr. Klaus, for this wonderful presentation. We may have one question from the audience. Okay, thank you. We'll move next to the next speaker, Dr. Iftikhar Kolo. He will discuss cardiovascular risk assessment, a contemporary approach. Thank you, Dr. Iftikhar.
Thank you very much. All right, so I'd like to just give you an update on contemporary risk stratification, at least in the US. And this is the outline of my talk. Risk prediction is difficult. What risk equation should I use? What are the adjuncts that can be used in assessing cardiovascular risk? When do we start screening? Should we start serial screening? And some summary and future directions, and some ideas at the end that may be pertinent to the Gulf countries. So risk prediction is difficult, and but it's, I think, useful for CVD because it's common and it's potentially lethal. It has a long asymptomatic period, and safe and effective therapies available. The problem we have is that we don't understand how this disease progresses with age. It does have periodic flare-ups, which may be due to instability in the plaque or inflammation that we don't fully understand. And it's a very complicated process. There are many features like calcification or thrombosis or endothelial dysfunction. There are many cellular players, macrophages and lymphocytes and so forth. And the morphology of the plaque sometimes gives a clue. So we have here a lesion that is compromising the lumen, but it's fibrotic and therefore probably less dangerous than something which is on angiography appears to be luminally okay, but lurking underneath that 20-30% lesion is this unstable plaque, which is lipid-rich and inflamed, and more likely to cause an acute cardiovascular event, as it happens when it ruptures, leading to thrombosis and an ST elevation MI. And the progression, as I mentioned, we don't understand. Some of us are luckier with our genetic makeup, and perhaps we progress less steeply with time, but others, due to risk factors and other genetic factors we don't understand, have a very accelerated course. And all of us, probably there are periods of quiescence in the plaque and then flare-ups, which are probably related to inflammation and other factors. So all of these factors make risk prediction quite challenging. So what do we have for available risk equations? Well, there are many of them: the Framingham, the Q-score, the Q-risk, the ProCam from Europe, which is applicable only in men, and the Reynolds equation, which is available in the United States. But more recently, the pooled cohort equations have been published from the ACC and AHA, which are now used in practice in the United States. So there are limitations with all of these equations. Just to take the Framingham risk score, for example, if you take cholesterol as one risk factor, you can see the distribution of cholesterol in the Framingham individuals that had CHD and that didn't have CHD. You can see that the overlap is quite substantial. So as a differentiator, cholesterol itself does very poorly. The Framingham equations are dominated by age. They only assess near-term risk, near-term being 10-year, and they don't include family history, metabolic syndrome, novel risk factors such as C-reactive protein. They don't take into account if the patient has chronic inflammatory disorders. And in women and younger subjects, somehow it's hard to get them into intermediate or even high risk. And their application to different ethnic groups is unclear. With the pooled cohort equations, at least one advance is that we can compute both near-term and long-term risk, and we now have equations that are separate for African Americans and European ancestry individuals. This is just a snapshot of what goes into the equation: gender, age, race, total cholesterol, HDL, systolic blood pressure, whether or not the patient is on treatment for hypertension, has diabetes or smoking. You enter these variables into an equation on the web or on your smartphone, and you get the 10-year risk. Now, you don't need to calculate risk if the patient in your practice already has atherosclerotic vascular disease. Obviously, he's high risk, he or she. If their LDL is greater than 190, the ACC/AHA feels that that's a threshold for treatment, regardless of what you can calculate by the equations. And then if you have diabetes, that again is an indication for aggressive treatment. So in these three categories, we don't need to calculate risk. Now, different from before, the categories of risk have changed, and now high risk or an indication for statin treatment is a 10-year risk of 7.5% or greater. Then the intermediate risk group, which formerly used to be 5 to 20, is now been shrunken to 5 to 7.5, and then low risk is less than 5%. Important feature of these new guidelines is the concept of shared decision making that was referred to earlier today, and this is where you engage in a discussion with the patient regarding the benefits and potential side effects and costs related to lifelong medication, and the physician not mandating but instead engaging the patient into making that decision. If you're uncertain of the risk of the patient because of other factors like family history, then that can be taken into account, and certain adjunctive tests can be done to further refine risk stratification, which I'll describe in the next few slides. Now, where did these equations come from? So these are actually from large cohorts that were funded by the NHLBI to study cardiovascular risk factors, and these include, of course, the original Framingham, but also newer cohorts such as the ERIC cohort, the cardiovascular health study, and the CARDIA study in the young. In total, there are about 11,240 white women, about 10,000 white men, 2,600 African American women, and 1,600 African American men. And these had a follow-up of about 12 years. All the events were counted, and these are the events listed here, so you can see the power for the calculations. And then at the end, we found that age, sex, systolic blood pressure, type 2 diabetes, smoking, and total and HDL cholesterol were the predictors of acute events. And these were then validated, and then the equations were published for use. So in our office, we see an individual patient. We don't see cohorts, and so the challenge is applying these equations from populations to an individual. And that's where some of the adjuncts are useful, and these will predict the risk of acute events, but it'll also give you a 10-year as well as a lifetime risk, in contrast to Framingham, where you just got a 10-year risk. The concept of shared decision-making I highlighted. So what are the adjunct measures? Well, the ACC-AHA recommends these four: family history, coronary artery calcification, ankle brachial index, and C-reactive protein. Let's discuss these. It's odd that an expert body should recommend family history as an adjunct, because obviously this is something one should do as an integral part of one's evaluation of the patient. Families with early onset heart disease are only 14% of the general population, but contribute to nearly 3/4 of early onset cases. So they're really a good target for prevention and treatment. Family history can be considered to be a free genomic tool. It incorporates multiple genetic variants, but also the shared environment in that family. Now the issues are, which is one of the problems the expert body had, was that there was no good data long-term about what is the actual risk of family history. And they range from a relative risk of 1.3 to as high as 11-fold risk when, for example, the twin has had, a monozygotic twin has had an event. We often say family history is present or absent, but it's more complicated than that. A family history of 3 of the 4 siblings having had an event is somewhat different than 1 out of 4 having an event. And so a family history score has been proposed, but is not yet utilized into practice. Unfortunately, the documentation in the health record is inconsistent, and so you've not learned a whole lot from the electronic health cohorts about the risk of family history. Coronary artery calcification by far gets the highest marks for its ability to risk stratify further those individuals that have an intermediate risk, and it's a relatively straightforward test. There's a small risk, small amount of radiation involved, but it has the best data of all the adjunctive measures. And we usually consider an abnormal CT scan to be one where the calcium score is high in absolute terms, greater than 300 units, or the score can be lower, but the score itself is puts the patient at the highest quartile in terms of age and gender. So you can see that these two examples on the left, a patient who has a high amount of coronary calcium and meets that 300 threshold. On the right, smaller amount of calcium, but for that age and gender, it's high. It's greater than the 75th percentile. Now, how to integrate with this information with the equations is not yet clear. One theory or one proposal is that we take the relative risk that's associated with high calcium and then multiply the 10-year estimate by that amount. Others have proposed a vascular age. So based on your amount of calcium you have on the CT scan, you compute a vascular age and then use that in the pool cohort estimate rather than a chronological age. As I mentioned, there's a small amount of radiation involved. It's not useful for tracking disease. You just saw in that elegant presentation by Dr. Nichols that actually with LDL lowering, the calcification might increase, and that doesn't mean the patient isn't doing well. In contrast, the patient may now have transitioned to a stable plaque. Calcification will miss soft plaque in younger individuals. So if you have a young individual who's 30 years old, 40 years old, has family history, a negative CT scan doesn't always mean low risk because the plaque may be soft and not calcified. And then in older men, calcification is almost ubiquitous, and this test is not very useful. How about C-reactive protein? This is a non-specific marker, and it can be elevated in the blood because of many things: trauma, infection, drugs, simply being obese. These factors release cytokines that act on the liver and cause the liver to make CRP. In the Jupiter study, there was some indication that patients that had high LDL but low LDL but higher CRP benefit from statins. But the heart protection study, investigators went back, looked at the data, and they can confirm it. So at this point, it's not clear whether CRP should be a determinant of when or whether to start statin therapy. It's non-specific. It's strongly related to obesity. In my practice, I can guess the CRP whenever the patient walks in the door. If they're obese, they're really likely to have high CRP. It's very strongly affected by estrogen use, and so in women you have to be careful because estrogens will really elevate circulating CRP. And to my read of the literature, the incremental predictive value of CRP remains unclear. But nonetheless, it has a fair bit of prospective data, and that's probably why the ACC/AHA put it in the category of adjuncts. Lastly, the ankle brachial index. This is a marker of lower extremity vascular disease. Normally, this index is about 1 or higher, but you can see that as the index gets lower, the hazard of dying is higher. So this is because of atherosclerosis in the lower extremity circulation. Now, the ACC/AHA recommends this as an adjunct, particularly in age greater than 65 or greater than 50 if they're smokers or diabetics. Now, the issues with this particular adjunct is that it's specific but not sensitive, so you need a fair bit of atherosclerosis in the leg circulation for this test to be abnormal. One can increase that sensitivity by exercising and then taking the post-exercise ABI. And this is actually going to be abnormal in individuals that already reach the threshold for high risk. So for example, diabetics or older individuals, they will already cross the threshold of 7.5% risk if you put those variables into the pool cohort estimate. So the incremental value remains unclear. And then in diabetics, sometimes you can have falsely elevated ankle brachial index. So we actually looked at these guidelines at Mayo across the enterprise, and we by and large agreed with them, but we suggested some modifications. These were summarized in this perspective that was published shortly after the equations came out, the guidelines came out. And we felt that the committee had been a bit harsh on carotid ultrasound. It got a grade 3 recommendation, meaning don't use. And I'll try to explain why we feel that's not right. And we further suggested two adjuncts, aortic pulse wave velocity, which is a marker of stiffness, and lipoprotein A levels. So let me first describe to you why we should consider carotid ultrasound. Now, the committee just looked at carotid IMT, which is a thickening of the wall of the carotid. They didn't take into account carotid plaque, which is very easily obtained when you do the scan. And in the ERIC study, which is a large cohort study of nearly 14,000 individuals, when they used both IMT and plaque, they could reclassify risk in 25% of individuals, which is pretty high. So this combination of IMT being elevated or plaque being present was quite useful in reclassifying risk, in contrast to just using the IMT, which is often difficult to measure in the primary prevention setting. And the American Society of Echocardiography actually also recommends screening by measuring not only the intimal medial thickness, but also looking at plaque. There are consensus recommendations for this because it's been used for many decades now, and there are appropriate use criteria. So I believe ultrasound of the carotid still has a place in risk stratification, particularly in younger individuals where the calcium scan may miss plaque because of its nature of being soft and not calcified. What about pulse wave velocity? Well, this is an excellent marker of vascular stiffness and aging. It's relatively simple to measure in the office setting. It just requires a tonometry and an ECG running at the same time. It calculates how fast the pulse wave travels from the carotid to the femoral artery. And the more stiff your artery is, the faster this value. Normal values in young, healthy adults are about 5 meters per second. And as we age, we can go twice or triple that amount, up to 15 meters per second. And in a study, we actually showed that this measure was correlated with the amount of calcification in the coronary arteries. And then subsequently, there have been large meta-analyses showing that it's an independent predictor of cardiovascular events. So this is not really in the guidelines yet, but I think the data is heading towards that, and hopefully in the next iterations, it will be acknowledged. Lipoprotein is a very useful marker in my practice. In contrast to C-reactive protein, which is just a marker, This is actually a causal risk factor. There have been studies, including what we call genetic Mendelian randomization studies, showing that genetic variants in your blood that increase LPA levels also increase your risk. So this is a causal risk factor in contrast to CRP. And we find that it's quite often elevated in individuals that have family history of early onset disease, meaning that it's one of the mediators of the risk associated with family history. It is very much like an LDL particle, but it has this repeat ApoA domain, which may be a mediator of risk. And I'm just showing you data from one study of men that showed that it was equivalent in risk to a cholesterol of greater than 240. So an elevation in lipoprotein A was nearly doubling the risk. But there are many studies confirming this observation. When should we initiate screening? Well, it's reasonable to do a pool cohort estimate starting at age 20 and then, or at least measure blood pressure and cholesterol at age 20 and then every 5 years. But the starting point is arbitrary. Obviously, you may want to do a risk assessment in younger individuals if they have other factors like family history or FH. And in terms of serial screening, one expert body called SHAPE has gone on to recommend repeat coronary calcium or IMT every 3 to 5 years. And this is a bit extreme. I personally don't like serial calcium scans because they're not very informative and there's radiation associated with them. There's some value in serial IMT, but it's very tough to do it in a private practice setting. You need to be in an academic care center where you have expert sonographers, and you need to make sure that they use appropriate landmarks so that the year-to-year measurements make sense. At this point, I don't think we can recommend it for routine use. And there's no data documenting that serial calcium scans lead to any improved outcomes or changes in therapeutic decision making. So at this point, serial testing with coronary calcium or IMT is not recommended. So let me summarize then the points I made so far. Assessing cardiovascular risk is obviously very important, but unfortunately 40 to 50% of individuals that develop cardiovascular events were not considered high risk by the profiles or the equations we currently have available. So we have a lot of scope for improvement. And it unfortunately is true that at this point, prediction of adverse events is only modestly accurate. Risk profiles for Asians and other ethnic groups, for example, Hispanic Americans or Hispanics, are not available. And in this situation, one just may need to use clinical judgment and adjuncts such as coronary calcification. I want to highlight that these are the risk categories that are now recommended for initiation of statin use, and also highlight the concept of shared decision making, where you take into account not only risk reduction but adverse effects, drug-drug interactions, and the patient's own preferences. And the adjuncts are listed here. The most useful one, in my view, is family history, followed by coronary calcium scanning, carotid ultrasound in certain situations. And then at Mayo, we do use pulse wave velocity. We have an established vascular laboratory that will measure pulse wave velocity, as well as carotid ultrasound, typically in young individuals that have family history. And the lipoprotein A levels we measure in, again, younger individuals, or if they have a family history. Now, as I mentioned, there's a lot of improvement that's needed, and so this is an area of ongoing work. Some of the areas where we might have some leverage is if we use multiple markers instead of just one. For example, CRP, there are data showing that if you use BNP, troponin, and CRP, you get much more incremental information. There's a lot of work, including at Mayo and in our laboratory, looking at genetic risk scores. Advanced imaging, for example, PET scan to detect inflammation might be useful. And of course, we need basic research to continue in atherosclerosis so we can understand the processes involved and thereby be able to develop new drugs and new techniques to detect disease early. And this will include statistical approaches as well, which is something that is very much used in weather prediction, where they have the benefit of very large amounts of data and can predict weather very accurately. But we don't have that data for individual risk prediction. But that might change in the future with multi-omics and other advanced imaging modalities. So this is basically a paradigm where you use the pool cohort equations and family history, and everybody and then novel markers and arterial functional imaging in a select group of patients. And this is a paradigm that we use in our practice at Mayo. Just to end with a few comments related to risk stratification in other countries, for example, the Gulf countries, where there are other risk factors, hookah smoking, processed food, high glycemic index, obesity, high salt intake, and perhaps other novel risk factors like lipoprotein, homocysteine that may be playing even a greater role in these special populations. There are psychosocial stressors, atmospheric pollution, chronic inflammation, and decreased physical activity that may also play a big role in the development of atherosclerosis in this part of the world. So what should we do? For example, if you were to do risk stratification here, I think we don't have specific equations, but the ACC pool cohort equations are a good point to start. Taking a family history is very important, and then one could consider subclinical disease assessment in certain situations with coronary calcium or carotid ultrasound, and then consider these other factors as adjuncts. So I'm going to end here and appreciate your attention and be happy to take any questions. Thank you very much.
Thank you very much, Dr. Iftikhar. Nice and elegant presentation. Any questions from the audience? Sure, Mohammed.
The problem of projectability and variability of the blood test in lipid studies. I mean, the tests, when you make the test today in two different laboratories, we may get some variation, is a problem. And the calcium score, I think there is also projectability problems as well. Taking a threshold of 300 maybe is questionable. Please, can you comment on this?
Yeah, every test has variability, and I think that you can get variability from different imaging laboratories for calcium as well, unless you follow certain quality QC measures and you have processes in place like what they use, phantoms, for example. So I think that those processes are followed in the US based on expert committee guidelines. And so I think generally the coronary calcium imaging scan and reports are are usually robust. But every lab test has a variability. And if you measure cholesterol in the same patient on a different day, it will be about 10% variability. So there's noise in every measurement, unfortunately.
I have a question of two titles. One of them is you've addressed the importance of family history.
Yeah.
We all know it's a non-modifiable risk factor. It's a non-modifiable risk factor, the family history.
Sure.
Do you see for the future things you've indicated that there will be a possible genetic intervention or something that will make this factor modifiable like anything else?
Sure. That's a great question. I would say that some elements of the family history are modifiable because they're environmental. So, for example, if there's a particular pattern of lifestyle or diet in a particular family, that might be modifiable. As far as the genetic factors, we are learning more and more about genetic variants that predispose us to coronary heart disease. Some of them are related to blood pressure, some are related to lipids, but there's a whole host of genetic variants that have been discovered that we have no idea how they cause risk. So there's hope that as we do more research on those variants that we will understand what processes they influence, and therefore we might understand the pathways that could be then drug targets. So in the future, I think doing a genetic risk profile and then finding certain variants might mean that that patient might benefit from a certain drug versus another.
Yeah. Any update on the poly pill or the statin for everyone, aspirin for the primary prevention? Like what's the threshold you see it and what do you see this coming on in the future? So aspirin for primary prevention and early utilization of statin because it's doing like magic as you can see.
Right. I think that's a very valid alternative versus trying to refine using other modalities for risk stratification. There's been a lot of support for that particular approach, particularly by Dr. Yusuf and others, where they are recommending that instead of trying to maybe enhance risk stratification, it may be better to treat. And there are some data showing that indeed it does lower risk. So I think that's a viable approach, particularly where you don't have availability of imaging and other blood tests, that you could do a very simple risk stratification and then decide whether or not the patient should be on a polypill. So I think in developing countries and other areas where the resources are not available, instead of trying to do a very in-depth risk estimation, one could simply just go to the polypill. There are, of course, pros and cons to that, but that seems to be a viable alternative. Yes?
Dr. Iftihar, thank you for a very good lecture. What do you do with somebody who has a LDL of 190, but a completely normal cardiac CT angiogram?
Okay. Well, that's a good question. I guess it'll depend on their age, and I presume that their pool cohort estimate is not high because they're younger. And so, based on the ACC/AHA guidelines, they would be candidates for statin treatment, even if their coronary angiogram doesn't show anything. And that's because they will, it may be genetic, and over the course of their life, they're at risk for developing atherosclerosis. So if you want to prevent that, then that patient may be a candidate. But again, I won't make a blanket recommendation, but I would consider statin treatment in that patient. Are you alluding to just a CT angio or a coronary calcium scan?
No, not coronary calcium.
CT angio.
So completely normal CT angio, and I have a number of 190. Do you treat those, or do you wait 5 years and repeat the CT angio, 10 years, whatever?
Well, what I would do in that particular situation is make sure, and it was referred to by the earlier question, you could repeat the test, right? You want to make sure that this is a truly elevated. You want to rule out secondary causes of hyperlipidemia. And then after you've done that, the cholesterol is still elevated, it's greater than 190, then I would consider treatment, even if the CT angio is normal. And I would do that with a shared decision making with the patient so that they understand why I'm making that decision. But I would lean towards treating. Yeah.
Thank you very much,
Thank you.
Dr. Iftihar. So now we think time to move forward with Dr. Stephen Nichols, triglycerides and cardiovascular disease.
Thank you, Mr. Chairman. I'm aware that I'm between everybody and lunch, so it seems fitting that we started this session focusing on one specific lipoprotein, which is of fundamental importance in terms of driving cardiovascular risk, and familial hypercholesterolemia has really become the prototype to really base that whole discussion around. But there is a sobering reality, which is that there is a whole bunch of other lipoproteins which are not all encapsulated within this figure, because I haven't included lipoprotein a. But what we appreciate is that lipoproteins are found in the systemic circulation. They differ markedly in terms of their size, their shape, their density, their lipid content, and what is often forgotten, and certainly has been forgotten for a number of decades, are a whole range of lipoproteins which are likely to be triglyceride rich, and certainly the levels of which will go substantially higher in your bloodstream about 5 minutes after you have lunch. And that has become an increasing focus of attention in terms of understanding their real role in driving cardiovascular risk and the potential to develop new therapeutics in terms of trying to lower risk further in statin-treated patients. We know that hypertriglyceridemia is intimately associated with insulin resistance, increasing production of triglycerides incorporated into lipoproteins in the liver, which are secreted into the circulation as VLDL, and then ultimately undergo remodeling within the circulation in response to an increased level of activity of a range of remodeling factors. Not only will that help to remodel those triglyceride-rich lipoproteins towards an LDL-type phenotype, but will also result in both smaller species of both LDL and HDL, potentially increasing the atherogenicity of both of those lipoproteins, in addition to the potential effects of the triglyceride-rich lipoproteins themselves. And a number of studies performed at the laboratory bench side have really now established that those lipoprotein particles are likely to have a number of biological properties which may in fact have a deleterious effect at the level of the artery wall. We know that those particles are pro-inflammatory, they're pro-thrombotic, they inhibit or impair fibrinolysis, they're likely to promote endothelial dysfunction, a number of factors that we all associate with an increasing progression of disease and increasing cardiovascular risk. It's important to note that those particles are not pure triglyceride particles themselves, that they will have some cholesterol content, and so these particles, in addition to all of those biological properties, are likely to also potentially accelerate atherosclerosis purely by their ability to deliver more cholesterol content to the artery wall and continue to drive foam cell formation and the inflammation that ensues beyond that. We've seen a number of population studies demonstrate that triglyceride levels appear to associate and be an independent predictor of cardiovascular risk. Here's the data from Framingham. According to gender, increasing levels of triglyceride associated with a greater relative risk of coronary heart disease. It doesn't matter whether that triglyceride is on a fasting or a non-fasting sample, and certainly we're seeing an increasing trend towards more blood draws being performed in the non-fasting state. Non-fasting triglyceride levels are also a strong predictor of cardiovascular risk in their own right. And then we see triglyceride levels being an important predictor of risk in the setting of different other lipid parameters. So here is data from ProCam demonstrating that an elevated triglyceride level associates with a higher cardiovascular risk in patients with both lower and higher levels of HDL cholesterol. Clearly the combination of high triglyceride and low HDL cholesterol, which is commonly associated in its own right with insulin resistance, is going to be associated with particularly high cardiovascular risk, and that atherogenic dyslipidemic phenotype that we're seeing increasingly more common in the setting of type 2 diabetes and abdominal obesity is associated with a fairly accelerated risk of cardiovascular events. The next observation comes from the outcome trials of statins, and that was that if you had an elevated triglyceride level, it really identified a patient who was at a higher risk of having an event, even if you treated them with a statin. Here's data from the heart protection study on the left and the care and lipid studies on the right, and the patients in grey who had higher triglyceride levels at baseline and on treatment had a higher cardiovascular event rate, suggesting that even the benefits that we saw with statins in those studies, patients were more likely to have an event if their triglyceride levels were higher. We see similar observations in more contemporary studies of aggressively treated, statin-treated patients following an acute coronary syndrome. Here is data from the PROVE-IT TIMI-22 study. Again, on treatment levels of triglycerides greater than or equal to 200 milligrams per deciliter, associated with a higher rate of death, myocardial infarction, or recurrent acute coronary syndrome at 30 days. So we see that risk factor associating with higher event rates really in large cohort studies in association with low HDL cholesterol, and regardless of the LDL cholesterol level and degree of statin therapy that patients receive. In our own experience using intravascular ultrasound, we've been able to demonstrate that patients with a triglyceride level greater than 150 milligrams per deciliter have a greater degree of disease progression. That's particularly highlighted in the setting of LDL and non-HDL, LDL cholesterol levels above and below 70 milligrams per deciliter. As I had said in my previous talk, our observation that you typically start to regress disease at an LDL cholesterol less than 70 milligrams per deciliter in patients with higher levels of non-HDL cholesterol, which is certainly a cheap surrogate of the overall atherogenic lipid kind of burden, or higher levels of triglyceride associating with either less regression in those patients or greater degree of progression in the patients with higher levels of LDL cholesterol. So again, I think the data from imaging and looking at the artery wall very much supports the cohort data and the clinical trial data. So what is the initial approach to treating hypertriglyceridemia? The one positive bit of news is the one lipid parameter which is relatively modifiable with a range of lifestyle modifications. So intense dietary fat restriction, weight loss, alcohol cessation, each in their own rights can actually have quite a profound effect in the hypertriglyceridemic patient. Many of these patients have associated type 2 diabetes. Improved glycemic control again has the capacity to lower triglyceride levels in its own right, and certainly is a patient who we more aggressively treat their diabetes from the first instance, checking for concomitant medications. And then from a lipid modifying perspective, the absolute first step should be to intensify statin therapy. They are the agents with the most evidence in terms of cardiovascular benefit. The high triglyceride has identified that patient as being a higher risk, needs to be more aggressively treated, and should be on high intensity statin therapy, and very consistent with what guidelines around the world are now advocating. We've seen data suggesting that having favourable effects on triglycerides can have a favourable effect on cardiovascular outcomes. Here's our experience from vascular ultrasound looking at patients with type 2 diabetes. In fact, altering the ratio of triglyceride to HDL cholesterol turns out to be the most important factor in terms of trying to slow disease progression in patients with type 2 diabetes. Again, it reinforces that concept that that is a particularly prominent and malignant lipid phenotype in these patients. And certainly it's very encouraging to see that having a favourable effect on that ratio can actually start to slow progression in a cohort of patients who are typically very difficult to control from an atherosclerosis perspective. Fibric acid derivatives are used worldwide as a commonly used agent to lower triglycerides. We've seen a number of studies over the course of more than 40 years now show a range of different effects of fibrates on cardiovascular outcomes. Some worked, some didn't. Here is a pooled meta-analysis that we reported in 2010, looking at more than 45,000 patients who participated in cardiovascular outcome trials of fibrate therapy. And the important take-home messages from this slide are the top result and the bottom result. The top result suggests that overall there is a borderline significant 10% reduction in cardiovascular events in patients treated with fibrate, but the patient who is most likely to benefit is in fact that patient who is hypertriglyceridemic, coming in a more than 30% reduction in risk if the hypertriglyceridemic high-risk patient is treated with a fibrate. And again, it very much re-emphasises the patient who we typically use these agents in clinical practice. We've seen the emergence of more selective PPAR modulators. We know that fibric acids are PPAR alpha agonists, but they have a range of other effects. We've seen a number of more potent PPAR alpha agonists and combined PPAR alpha gamma delta agents in clinical development in the last decade or so, almost all of which have gone by the wayside largely due to problems with toxicity and off-target toxicity. The emergence of the selective modulators allows for a more targeted ability to lower triglyceride, potentially raise HDL, without necessarily having a number of the other effects that we've seen in those other programs that have kind of come and gone over the last 10 years. Here you see lipid data from the hemifibrate experience showing robust reductions in triglyceride levels. And that has led now to the launch of a large clinical outcome trial called Prominent, in which patients with high triglyceride and low HDL cholesterol will be randomised to treatment with pemafibrate or placebo on top of statin therapy. and in terms of looking at cardiovascular outcomes. Omega-3 fatty acids, again, a therapy that can be very effective in terms of lowering triglyceride levels, but has had perhaps peaks and troughs in terms of degrees of evidence over the last 25 years in terms of their effects on cardiovascular events. Early data that preceded the statin era suggesting potential benefits of omega-3 fatty acids in fish oil. A whole range of studies, largely using low doses of omega-3 fatty acids in the wrong patients with essentially normal triglyceride levels, have failed to show any benefit. But more recently we've seen some more encouraging observations from studies. Here is the JELA study, a large cardiovascular outcome study of more than 18,000 individuals in Japan, treated with statin alone or statin plus nearly 2 grams a day of EPA. And you saw that a relatively low degree of triglyceride lowering, 5% in fact in that study, associated with a 19% reduction in major adverse cardiovascular events. In fact, in Japan, EPA has very much become guideline-based therapy for high-risk CV patients, particularly those who have elevated levels of triglyceride. We have 2 large cardiovascular outcome trials which are testing this hypothesis in a more global setting. We are leading a study called STRENGTH, 13,000 patients who are at high risk of vascular disease, either established ASCVD or high-risk primary prevention. As you can see on this slide, patients have to have a triglyceride level greater than 150 milligrams per decilitre and a low level of HDL cholesterol to get in, but then are being treated with 4 grams of EPA or DHA, a sufficiently large dose to test in a large clinical trial or a corner or placebo, and we're looking at the fairly typical cardiovascular endpoints that one would expect to see in a trial such as that. In parallel, there's a study called REDUCE IT, which is looking at a pure EPA approach, again at high doses, similar type of cohort, high risk, high TG, low HDL cholesterol. In fact, many of us are wondering whether we'll see the result of REDUCE IT sometime over the course of this year. So we now may start to see the emergence of more definitive results telling us whether high dose omega-3 fatty acids will work in the hypertriglyceridemic high-risk patient. We've also learned a lot more about the factors that are involved in the regulation of metabolism of triglyceride-rich lipoproteins. Lipoprotein lipase plays a pivotal role in the hydrolysis of these lipoproteins. In fact, we now have identified a number of factors, in particular ApoC3 and angiopoietin-like proteins 3 and 4, which both inhibit lipoprotein lipase and therefore have the potential to raise the level of triglyceride-rich lipoproteins considerably. They may have a number of additional biological properties that may be deleterious at the level of the artery wall, but they have now gained incredible interest in terms of being new targets for therapies. And one of the reasons why is because there's now a large body of genetic data that really very much links inactivating mutations of either ApoC3 and angiopoietin-like 4 with both lower levels of triglyceride and predictably lower levels of cardiovascular risk, suggesting that from a genetic perspective it really places these more triglyceride-rich lipoproteins like LDL cholesterol on the causal pathway for disease, and therefore would suggest that targeting those factors may be more likely to derive benefit, as opposed to the disappointments that we've seen over the course of the last 15 years with HDL raising, which has consistently proven to be disappointing in large-scale clinical trials. Here you see data from Framingham showing that high levels of ApoC3 not only associate with high levels of triglyceride, but they associate with higher levels of cardiovascular risk. We've seen antisense therapy emerge against ApoC3, and in both preclinical and now in human early clinical studies, we see dose-dependent reductions in ApoC3 and triglyceride levels in the up to the order of 70%, and so potentially gives us the next big target to take to a larger clinical trial. In parallel, we've seen monoclonal antibodies developed against angiopoietin-like 4. Here you see the preclinical data, again showing very robust reductions in triglyceride levels in association with reducing the activity of that target. And in fact, in a quite provocative early study, in fact, this agent has effective LDL cholesterol lowering, and here's data from patients with homozygous FH, suggesting potentially an earlier clinical pathway for this approach while we wait to sort out what it does in terms of cardiovascular outcomes, in terms of its triglyceride lowering effects itself. So in summary, we talked a lot about lipids in the last hour and a half. And from a cardiovascular perspective, this slide very much summarises where we continue to battle in terms of patients and lipids. On the left, unfortunately, are where most of our patients are. They have too many atherogenic lipids and not enough protective lipids. The natural history there is for ongoing accumulation of lipid within the artery wall, ongoing inflammation. Their plaques will get bigger, they'll be more inflamed, and they'll be more unstable, and they're more likely to have a cardiovascular event. We continue to need to get as many patients as possible to the right-hand side of the slide, where the ratio of atherogenic to the protective lipid species is much more favourable. In that setting, then, we'll see smaller plaques, and the plaques that remain will look more stable, be less likely to cause a clinical event. It's likely to be that for many patients, particularly in a world of increasing abdominal obesity, that combination therapy will be needed to achieve those effects. It's really come time now for a lot of these triglyceride therapies to be fully evaluated in large outcome trials. And on that note, I'll thank you for your attention.
Thank you very much, Stephen, for the elegant presentation. Any questions from the audience? Yeah, there's one here.
Thank you very much for this wonderful lecture. From a clinical practice perspective, unlike LDL, where there is a number where we refer to, in your practice, is there any number of the triglyceride that you decide that I will treat at that number? Presumably the patient is already on statin, etc. B, if you decide to treat, do you tend to increase the dose of statin to the maximum tolerated, or where the benefit of triglyceride is small, or you add, for example, a fibrate? Thank you.
So the second question is easy to answer than the first. Step number one from a therapeutic perspective is after lifestyle is going to be intensification of the statin. One of the challenges in the triglyceride space is that we're still operating in a bit of a data-free zone. I see the triglyceride story probably at a number of different levels. If your triglyceride level is greater than 5 millimoles per litre, or certainly 500-600 milligrams per deciliter, then I think you're in a situation where we're treating, but we're treating for lots of reasons. Not only are we treating to lower cardiovascular risk, but we've got a pancreatitis risk, which is substantive. And while the medical community has become quite comfortable with the idea that we would treat extremely high triglyceride levels with a fibrate to lower pancreatitis risk, there was never a clinical trial that was ever conducted. So those guidelines are informed by nothing. The bigger challenge is what you do with the patient with a more modest elevation of TG in that kind of 150 to 450, 500 range. I tend to be on the more aggressive side, so I will be more inclined to intensify statin therapy and then look to add a fibrate fairly early on. Some of my colleagues who may, certainly in North America where niacin is certainly more extensively used, might be more willing to use that agent fairly early on. But again, we have no data to genuinely support that. I tend to do that because I think that's a very aggressive dyslipidemic phenotype and that patient's high risk. I will expect at some point one of these clinical trials will show benefit. The question will be which of those agents it will be, and how quickly we can get that evidence.
Thank you. So if there is no further questions, I think it's time for us to end up the session. I want to thank my speaker colleagues and my co-chairs and the organizing committee of the conference. And we'll hope we'll see you at 2 p.m. in a very interesting session of valvular heart disease. Thank you.
Inshallah, Friday prayer will be in the VIP lounge. Then there will be a symposium by pharmaceutical companies here for Sanofi and Servier. Thank you, inshallah. So.